Life Link III provides on-scene emergency response and interfacility transport for over 2,200 adult, pediatric and neonatal patients each year, serving 9 leading hospital systems in Minnesota and western Wisconsin. In 2013, Life Link III replaced its entire ventilator fleet with 9 new HAMILTON-T1 ventilators.
The HAMILTON-T1 is currently the only ventilator on the market that allows us to provide a continuum of care from the referral agency to the receiving hospital. It's the only ventilator that's geared towards transport in a manner that we can continue exactly what the referring hospital or ICU is expecting to put that patient on for ventilator settings.
When we implemented the T1, I feel like the drastic change to our patients was that we were able to get on top of problems faster than our previous ventilator. The ability to have constant feedback and things like a dynamic lung and really nice flow and pressure graphs is that you can see changes breath to breath and trend them a lot better than ventilators that don't have a really nice touchscreen. When we got the HAMILTON-T1, I feel like one of the things that changed was most of the patients, even for a 7-minute flight, started to go on the vent because we realized the change to the patient could actually be made in that short amount of time. So we could actually make a difference in that short transport.
Obviously, one of the gross differences between the HAMILTON-T1 and the other manufacturers was a dual limb circuit, which was unusual in the transport environment. The transport ventilators have always been a single limb circuit, which kind of cripple our ability to monitor our patients in real time, meaning breath-to-breath metrics.
You get so much info, breath to breath, that you can make faster, more accurate clinical decisions. That was one of the things that really surprised me of how much that changed my care.
They can begin lung protective strategies early on with using ASV, while they can pay attention to the rest of the patient and continue to assess them for other injuries or further assess their illness.
It's specifically really advantageous in trauma because you have so many other fires to put out that it's nice to just set up the ventilator for the patient's height and their ideal body weight and then allow ASV to manage the patient from the lung standpoint. The fact that once you get the patient's height and ideal body weight plugged in, it's fairly easy to set up. There's probably 5 or 6 settings from like FiO2 to peak inspiratory pressure to PEEP. And once you have those set up, ASV does a really nice job of transitioning from assist control to SIMV to spontaneous all on its own based on the patient's work of breathing and their effort. And the fact that it's calculating thousands of times per minute exactly the patient's work of breathing, their respiratory status, their exhaled flow rates, their tidal volumes, everything. I think there was a lot of comfort that came from that. It's not set and forget, it's constantly reevaluating the patient, and that gave us a lot of reassurance.
Having a way that we know that we're providing the most protective, that we're employing the most lung protective strategies that we can en route using a ventilator, knowing that prolonged ICU stays cost money, we're likely seeing a return on investment at our receiving hospitals that are taking care of the patients that we transported because we started lung protective strategy ventilation early on.